You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Hello, and welcome to this episode of International Perspectives on Dry Eye Disease. I'm your host, Dr. Laura Periman. In this series, clinicians from around the world are going to comment on some of the under-discussed aspects of dry eye disease that are sometimes glossed over. In this episode, we will be reviewing which underlying systemic conditions clinicians should consider when evaluating a patient during a dry eye consultation. In future episodes, we'll review which underlying ocular conditions are most relevant to dry eye, and we'll discuss the patient journey and experience. But now let's dive into our first episode. I'm so pleased to have my guests here today. First, I'd like to introduce you to Dr. Mile Brujic. He is a partner of a 4-location practice in Northwest Ohio called the Premier Vision Group, and that's in Bowling Green, Ohio, where he practices. Welcome, Mile.
Hey, Laura, thank you for having me on.
Awesome. It's great to have you here. And then second, I would love to introduce Dr. Victor Perez. He is professor of ophthalmology and director of the Steve Foster Center for Ocular Immunology at Duke Eye Center in Durham, North Carolina. Welcome, Victor.
Hi, Laura. Great seeing you, Melly. Thank you. Good to share the podium with you, and looking forward for a healthy discussion.
Excellent. So as seasoned dry eye doctors, and we're all dry eye nerds, right? We love doing this. We see these patients day in and day out. It's not uncommon to be the first to diagnose systemic underlying conditions because they can contribute to the dry eye situation. And have you encountered that frequently in your practice, where you're the first to figure out the underlying systemic disorder?
I mean, in my practice, I do, because, it's a bit more of a specialized practice, but that's what we see. We see patients with inflammatory diseases of the eye, and the eye and the dry eye is not any different. It's part of that umbrella. So I see a lot of patients that, have some form of inflammation, and looking into that, you have to examine the patient, get a good history, and you're sure you'll find some systemic disease.
I think it's interesting too, Victor, that sometimes the symptoms that they present with locally will actually be manifestations of things that are happening systemically as well too. Laura, you are aware of this, but in undergrad, I was a biology major with a biochemistry minor, and I spent a lot of time in immunology. And it's interesting to see how everything's intertwined. And as much as we understand and know about healthcare, we realize that there's just as much that we don't know, and we're learning on a daily basis. But it's also interesting too, with respect to the medications that individuals are taking for some of these systemic conditions. I'll give you a perfect example of what I mean, Laura. And this is something that I think all of our colleagues need to just be very aware of. We have a patient who has non-inflammatory dry eye disease. Every time, should say, a non-elevated levels of MMP9 dry eye disease. I see her every 6 months for new intracanalicular punctal plugs. She does remarkably well with them. Every single time I test Inflamadry, she's negative on that test. And the last time she said it didn't work quite as well. When we asked her more about the symptoms, we realized she was taking a decongestant nasal spray. So it's something that totally threw it off, and it misperceived her perception of what the treatment actually was. So I think there's systemic conditions, and I also think the treatments that these individuals are going under can kind of derail our efforts as well too.
Yeah. When I give this talk, I have this slide that I present an iceberg, and the tip of the iceberg is the eye. And below are the things that can present infections, systemic diseases, autoimmune diseases, and the ocular surface is in front of us. So we can tell that something is wrong and pursue further investigation. And I can tell you off the bat, patients that may have some form of autoimmune disease, and by that I mean the common ones, rheumatoid arthritis, inflammatory bowel disease, non-systemic diseases, look for ocular surface inflammation and dry eye, because most of them will have them.
I agree. And so many times when we're doing that examination, looking at the tip of the iceberg, as Victor so astutely calls it, if you just take just a little step back, you'll start to notice dermatologic features that can tip you off to certain systemic disorders. I never used to really think of rosacea as a systemic disorder, but turns out it is. There's a gut dysbiosis, there's association with cardiovascular disease, with diabetes, with triglyceridemia, all kinds of systemic components to their whole body, and it shows up in our clinic as ocular surface disease. What other dermatologic conditions do you run into that that have a systemic component to ocular surface disease when you're examining a patient?
One of the most common that I see and very important to recognize, are patients that have a little bit of cicatrizing changes in the surface too. And you have to think of immunobullous diseases, especially for elderly patient with pemphigoid, or lichen planus. I mean, they fall within that category, and they need to be diagnosed and treated accordingly.
And the treatment's very different, right? I've treated
Absolutely,
like
systemic therapy. The other disease that I think it's important, and that's one of my main messages, patients that receive a bone marrow transplant for a leucemia or a genetic disorder, 60% of those patients will suffer what is called graft versus host disease. And it's the donor cells that affect different tissues. The skin, the bowel, and the ocular surface, 60% will develop dry eye. So if you have a patient that receive a bone marrow transplant, you really have to keen into looking at the ocular surface and evaluate ocular surface disease, which I think we'll cover in our next chapter.
Or one of the things too that I think is so important for us to understand. So when we walk into the room with a patient, we're so locally focused on what's happening. I love your idea of pulling back just a little bit, because we treat dermatitis all the time around the tissues of the skin. And how frequently do we ask about other areas that may have that same dermatitis response? And I think that is critical for us, because oftentimes they won't manifest these other symptomatic places. I think the tissues around the eyes are so sensitive that we may be the first people that they're approaching on this journey to future diagnosis of this. So I think it's critical that we take a step back and ask about other spots or areas that have the same type of dermatitis response.
That's a great point. And I may include the mouth. Always look at the mucosa of the mouth, at the nose. Patient may have severe dry mouth and they don't realize, and you see ulcerations. Or these patients with immunobullous diseases may have lesions in the mouth too. So, yeah, look everywhere. I think that's a very important point. And, we vision clinicians are not used to that. And, we really need to teach our students and keep in mind to ourselves that, yeah, we need to look in other places beyond the eye.
I love that. I call that the water bottle sign. Your dry patient that's constantly
That's
working on
correct.
their water bottle. It's like, oh, do you suffer dry mouth? Oh, yeah. Do you have problems with your teeth? Oh, yeah, I'm at the dentist all the time. It's like, okay, let's run some labs to look for systemic autoimmune conditions. But I think you can see a lot inside of a mouth just by looking inside of the mouth. Like structural things, like a high arched palate can suggest Marfan syndrome, and that has connective tissue considerations, excess laxity of the skin, like Ehlers-Danlos syndrome, and all of these really subtle phenotypes that are out there with hyperflexibility and that can affect the lid and the mechanics of spreading that tear and ocular surface tear distribution. So yeah, the dermatology piece is very interesting, and I love it that you're looking inside the mouth for other signs of mischief, asking the questions. Well, do you have any other itchy spots on your skin? Like screening for atopic dermatitis, screening for rosacea. And it turns out getting that right could lead you down different treatment pathways, right?
Laura, I would go as far as to say I love the things and the topics that you're bringing up, because a lot of times, just as important as it is to diagnose dry eye, it is important to also rule out other things. And the elasticity of the lids is critical. I think one of the most overlooked conditions that we see in eye care are floppy eyelid syndrome patients. These patients
Great.
come in the office every time, and they have this kind of plethora of treatments that they're undergoing. When in actuality, it's a simple treatment. Keep these eyes covered in the evening, whether it be some form of mask or whether it be some type of surgical intervention, and their symptoms immediately go away. But again, we have to be very cognizant of a lot of these things. And because of the systemic association with sleep apnea, we diagnose 3 to 4 of these patients a week, or we confirm the diagnosis that they forgot to tell us about. And that leads to a whole other plethora of things, because if they do have sleep apnea, they're usually using masks. And that is another risk factor for dryness that's going to be difficult to treat with standard treatments. We got to take a step back and think about what's actually causing this problem, rule out maybe dry eye, and let's figure out the mechanical challenges that these individuals are having with just physical air blowing against their eyes in the evening.
I love that. And the clinically, that triad of excess lid laxity, temporal eyelash ptosis, and that papillary conjunctivitis is your clue. And it can be subtle. And don't let somebody's BMI fool you. I've seen teeny tiny, petite, thin patients with sleep apnea that needed treatment with CPAP. And some of those
Right.
eyelash changes are somewhat reversible with good therapy.
The other clue that we should look for diagnosis, when you talk to the patient, try to identify if there's any personality disorders, depression, liability, ways that mood switch, and also autism. And the reason I mentioned this because this patient, dry eye might be, again, the tip of the iceberg of a nutritional deficiency. I mean, these patients will tend to don't eat well, that especially, vitamin A, things like that. And they can, present with an ocular surface disease that really the treatment is, taking care of the psychiatric component of these patients and nutritional supplements.
Oh, that's great. And you have screening for a history of gastric bypass surgery, right?
Bingo.
That would justify deficiency as well. And all kinds of, like you said, neuropsychosocial complications from that nutritional deficiency. And, the floppy eyelid is associated with poor sleep, and that'll make you grumpy all day, every day. I don't blame them one bit. So it's fun to watch folks that you identify and get them the right treatment path, watch them, blossom and become a more energetic, happier, healthier version of themselves. All right, we're going to take a quick break, and when we get back, we'll look at how these factors might affect patient treatment. Thanks for sticking with us. Now that we're back from break, we'll do a little bit of a deeper dive on treatment options for patients with systemic diseases. Mila, I was interested in your comments earlier about your allergic patient. And let's talk a little bit more about that, like the medication list and like what the treatment options are and how to really direct that. And what is the association between allergic conjunctivitis and rhinitis and ocular surface disease? Is there an immunologic bridge?
Yeah, I'm glad you asked this, Laura, because I'm a big person in the philosophy of making sure we take the time to adequately diagnose patients. I think we're sometimes so transactional in eye care that we walk in, we already think we know the answers. I'll give you a perfect example of what I mean, Laura. This happened to me about a decade ago, and ever since then, my technicians have asked this question different. But I had a patient tell me her eyes were itching. I prescribed olopatadine 0.7% to use once in the morning, saw her back for a week follow-up. Her eyes were worse. And when she showed me how her eyes were worse, she was actually itching the skin on her lid. So that's one of these situations where you do the no charge office visit. We're going to treat you now for exactly what the problem is and figure out why your lids are itchy, whether there's something that you're exposing yourself to or it's something that's more broadly ranging. But there's really 4 different types of itching that I've found clinically that are highly specific for certain conditions. One is the skin itch. That's obviously some form of atopic dermatitis. There's the eyelid margin itch, and that's the blepharitis. There's the itching in the lower fornix or the mucus fishing syndrome. Then there's the knuckle rub in the corner of the eye, which is allergic conjunctivitis. And then there's the 5th rubbing, where it's this kind of non-specific diffuse rubbing that can be associated with a lot of the things that we deal with in our patient base. But I think it's critically important to ask about any medications that patients are taking, because if they don't report antihistamines that they're taking and we don't know about it, which oftentimes happens in eye care offices, we're completely missing the boat and going in different directions. So I think it's critical to accurately identify these individuals, Laura.
I mean, I totally agree. This is very important. A lot of these patients will have severe, skin disorders and allergy, and they require, there are different treatments that can help also the eye. First of all, there's some specific ointments that you can use the same thing they use in the skin can be used around the surface of the eye, more specifically, Protopic or Prograf, it's an anti-inflammatory ointment that helps significantly the periocular tissue. And then systemically, these patients can be treated with low-dose cyclosporin, which helps systemically and eventually will help the eyes. You can work with dermatologists to do this. And nowadays, there's so many a new plethora of biologics, antibodies that work really well, in the lungs and the skin that can also be used to trick the eye. And, that's very important to have identify that and refer accordingly.
I agree. The dupilumab for atopic dermatitis is quality of life changing for these patients. And the thing about one of the consequences is if the atopic dermatitis patient who gets dupilumab, or Dupixent is the trade name, and they have a history of atopic keratoconjunctivitis, they can end up with a rip-roaring Th1, Th2 ocular surface disease called dupilumab-induced ocular surface disease. And it's an impressive presentation. And the temptation is to stop the drug, but you can get them through it with your steroids, your tacrolimus. We published on a case of IPL helping the dupilumab-induced ocular surface disease. So I think the temptation is to back away, but really we should roll up our sleeves and double down and get them through that dupilumab-induced ocular surface disease.
Absolutely. We have the target organ in front of us, so we can really be a little bit more aggressive in controlling these responses so the patients don't need to get off systemic medications that are happening systemically. And in addition, I can tell you of the ocular structures that are affected with the skin allergic diseases, meibomian gland dysfunction. I see these patients evolve in front of me in a more advanced fashion. So going to your point of using IPL, I think it's a very great idea to be aggressive looking at the meibomian glands.
And I'm glad we're talking about common things like allergic keratoconjunctivitis and rhinitis, because actually this work was done out of Duke with Danny Sabin and Nancy Reyes, where they showed there's an immunologic bridge between allergic conjunctivitis and MGD. And I think that's really interesting. And to my understanding, and correct me if I'm wrong, there's only a handful of things that block that bridge. First of all, you want to stop the inflow, but then you've got steroids, you have lifitegrast, and you have IPL. And that's kind of it for stopping that poly-driven driver to MGD.
Yeah, and we identify by doing analysis of the cells in the tears of these patients, a new population of inflammatory cells that we never thought about it. The neutrophil. I mean, we know they exist, but interesting, these might be the either orchestrators or the effector cells that take care of the meibomian glands downhill.
So Laura, what's interesting, I work with a lot of pre-optometry students in our office. So we're home to Bowling Green State University, and because of that, they see a lot of and work with a lot of these patients and some of the more severe forms. And it's part of the reason why even this discussion, why I share with them, this is why we treat early, because we want to avoid the long-term downstream consequences that we're now talking about. When we can avoid this and treat early, we can avoid, I think, a lot of these long-term ramifications from a lot of these chronic inflammatory conditions. And I think protecting the eye is our duty in these patients, which is one of the reasons that I am of a strong philosophy that the sooner we can identify these patients with ocular surface disease and put them on appropriate paths to control some of this inflammation, the better the long-term clinical outcomes will be for them.
I love that. And thanks for bringing that up, like the burden of disease and the duration of disease prior to diagnosis. And we have some pretty strong data around the delay in diagnosis to Sjogren's. It's like over 4 years. In the study of recalcitrant keratitis that Melissa Toyos published recently and treated very successfully with Acthar, their duration of disease was around the same period of time of that long period of time. And so when you have that patient who's continuing to come in and needs help, what's your threshold for really rolling up your sleeves and shifting gears and offering something different, or taking a fresh look at potential misdiagnoses?
I mean, my threshold is very low because, I see a lot of these patients.
Yes,
I love the example of Acthar, which is this cortisol stimulating in gel that is used systemically. And patients will tend to freak out a little bit at the beginning when you tell them you need to use systemic medications to help the ocular surface. But that's okay. Like you said, roll up your sleeve and walk them through what the plan is. And for me, is trying to control your surface inflammation, with not chronic use of steroids. And for that reason, just like dermatologists and rheumatologists, we move quickly into what we call steroid-sparing therapies. Now, having said that, unfortunately, in contrast to other inflammatory diseases of the eye, like uveitis, scleritis, where the use of systemic steroid-sparing therapy works incredibly, black and white. Dry eye is not that much. And I think, to your point, that, maybe if we find a Sjogren's patient early on, we still have some, lacrimal gland to work with. A lot of these patients come too late. And despite our efforts of immunomodulating their systemic immunological system, it doesn't work as clean as other inflammatory diseases of the eye. So yes, low threshold, roll up your sleeve, and be aggressive with the therapy, identifying what these patients need.
Emilio, I think I'd love to hear your thoughts about implications for primary eye care, like, catching this earlier before the lacrimal gland is burned out from chronic inflammation. Like, what are some of the little subtle things that we need to be encouraging our colleagues to look for to catch this earlier in the disease states?
Well, a few things that I would just recommend. One is a lot of times we get inundated in the details on the technologies that we use to manage these things, but there are such easy screening tools that we can use just to catch these patients quickly. Literally pulling their upper and lower lid when they're sitting in the exam chair, we can get a gross examination of the meibomian glands. It's not as accurate as infrared. It's not as accurate as eyelid transillumination, but we can get a sense of where their glands are just by physically looking at them with the naked eye. I'm doing things like incorporating fluorescein, which is an easy test and an easy thing to incorporate in the anterior segment examination. It's just easy to do, and it tells you so much about the tear film in the ocular surface that's, for most individuals, absent in a standard white light assessment. And really using the cobalt blue light and the Ratten filter in place, which literally takes a white light slit lamp examination and just makes the invisible, I should say, visible. And that's where you start to see these early modifications and changes. And when you simply ask these patients simple follow-up questions about eye discomfort, you immediately start to see they're either using things that are over the counter where they're trying to mask these symptoms, or just simply not doing things that they want to be doing. I think systemically we have a massive role. It's part of the reason why we recommend ocular nutrition. And I think there's a lot of benefits to a lot of the technologies that we have and a lot of the things that we know about as well, too, in particular omega-3s. I know there's a little bit of controversy around the data coming out of the DREAM study, but I do think there's still a role for ocular nutrition for these individuals as well, too, in particular early on in the condition.
And then when your patient's progressing faster than you would think, or is not responding to the easy treatment recommendations the way you would expect, those would be like little hints, little whispers that maybe you need to look deeper, right?
The most common question I get from dry eye patients today is why am I developing this condition? And I think that we can all identify the reason. We just might not have all the pieces to the puzzle. And as we see these individuals for follow-up, pieces to the puzzle start exposing themselves. And I think the more curious we stay about these individuals, the more we can play a greater part in the bigger healthcare picture of these individuals. So I do think that we're going to look back in 10 years from now, we're going to look back and say, yeah, we just used to think dry eye was kind of this local manifestation that some people developed. And I think we're going to see that, oh yeah, these are associated with systemic conditions that we either didn't even know about, or we just didn't link to these individuals that we're going to have direct connections to. And we're going to look at this not as a local treatment. We're going to look at this as a local treatment to a systemic manifestation.
Which is awesome. All these tools are coming available to us so we can be targeted and specific and customized treatment plans for these patients.
And, as we all have mentioned here, always, if things, you need to turn off the slit lamp, turn on the light in your room, talk and examine patients, and you'll make better diagnosis.
Well, this has been a very enriching discussion. I wish we could go on longer, and I think we should submit like a course to lecture on all this stuff. I think it would be really fun, and we could really deep dive onto all these topics and all the innovations that are coming about in the future. I can't wait. Dr. Brujic, Dr. Perez, thank you so much for joining me on this episode of International Perspectives on Dry Eye. And thank you to the listeners for joining us as well. Remember that we've got 2 more episodes in this miniseries coming your way. So be sure to subscribe to the podcast so that you can hear those episodes as they appear in your feed. For now, I'm Laura Periman, and thank you for tuning in.